Welcome to the Profile Series. I'm Terry Duenas, and you are going to be so pleased today that you tuned in to listen to some of our health leaders from the Duffy Health Center. And let me introduce our folks. To my left, Louise Patrick. She's the Director of Behavioral Health.
Behavioral health, that's correct.
Behavioral health. Behavioral health. You better behave. You don't get help. Behavioral health. And the new medical director for the Duffy Health Center, Dr. Wesley Klein. It's a pleasure to have you here, Dr. Klein. And Duffy is, I'm sure, excited about having you with them. And to his left, again, the hardest working lady in show business and healthcare, Elise DeGroot. And Elise is the Director of Community Relations and Marketing for the Duffy Health Center. And again, Elise, thank you for putting this all together. And earlier I made Heidi Nelson, our Duffy's executive director, promise that she would come back. Before she even left, I got her to promise she would come back. So that's great. So it's a pleasure to have you all here. We're going to learn a little bit more about what Duffy is doing in and on Cape Cod. So it's great to have you. And Elise, I'm going to put you on the spot right off the bat.
Sure.
I'm going to have you tell us a little bit about what Duffy is and its mission.
Sure. So Duffy Health Center, we are a federally qualified healthcare for the homeless community health center. And our mission is to prevent and end homelessness across the Cape. And we primarily do that through an integrated model of care, which includes medical care with Dr. Wesley Klein, behavioral health care with Dr. Louise Patrick. We just got a promotion, Louise. Dr. Louise Patrick.
Wow.
Louise
Just got my
PhD. Director of Behavioral Health. And then we also have case management services at Duffy. So instead of just treating the medical problem, when people come through the door, we really try to take a look at the whole person.
Wonderful.
So our mission is to prevent and end homelessness for people who are homeless on Cape Cod, but we also are reaching out to people who are at risk of homelessness, and that's a really important thing to keep in mind, because there are a lot of people who we think we can offer services to who may not realize that they're qualified to get services at Duffy. So people who may be doing something what we call couch surfing, they're living with friends or neighbors and they may not have a place to stay of their own. There are people who are at risk of homelessness, so they would be qualified to come in and get services at Duffy. Two people who have their name on a lease, well, one person has their name on the lease, the other person doesn't. The person whose name is not on the lease, they're at risk of homelessness. Lots of ways people can be qualified for our services who may not know it. We just want to get the word out so that people know that they can come in and see us.
Wonderful.
Yeah.
I think that's such a great model to attack the homeless problem, that you're not just there to help the homeless.
Exactly.
You're there to prevent homelessness, which...
Well, it makes a lot more sense to try and prevent it before it happens than to try and get people out of it once they've fallen into it.
And that I was under the misconception that you just somebody had to be homeless before they came to your services.
That isn't true.
I think many people think that, yeah.
Now, the component of dealing with behavioral health issues is certainly not new to the problem of homelessness, but maybe new to the services that Duffy is providing, correct? How long have you been involved, Louise? I've
been at Duffy for 5 years, and we've had an integrated care model the whole time I've been there. It's one of the things I really appreciate about working at Duffy is, although it's a health clinic, behavioral health and case management we think of it as a three-legged stool, that it's not just about primary care. Sure. That behavioral health care and case management services have equal weight and are equally important as primary health care. So it's like a three-legged stool in the sense that if you take one away, it's unstable.
Right. Absolutely. Are there any medical issues that you find, Dr. Klein, that are unique to the homeless population or the potentially homeless population?
Yeah. I don't think they're unique, but I think they're more of a problem. I think the two biggest ones are chronic mental illness and addiction and alcoholism. Excellent. That seems to be something you see that's a common contributor to the problem.
So if you can deal with some of these other problems,
right,
such as substance abuse, it might help eliminate some of the other health problems?
Yeah, sure,
Right.
absolutely.
Great.
Someone's not going to take care of their diabetes or hypertension if they're a heroin addict.
Yeah, that's last on my list.
Exactly.
Sure.
Yeah.
There's a lot more things. So they can't even get into those things until they get clean from drugs or alcohol. So that's often the first thing you have to work on.
Well, I'm so impressed in full disclosure, we taped a program, an earlier program, and I learned a lot in that from Heidi about the different programs that you're doing. Anything that we should know about some of the programs that you're doing since your medical directorship has, you've kicked that in?
One of the things, it started before I got there, but we've been working on something called patient-centered medical home. It's actually a concept that started many years ago, but has kind of taken hold as a way of doing primary care and integrating it with kind of a whole patient, a whole person perspective. And the idea being that often in U.S. healthcare, it's very fractured, meaning you know, you'll see a cardiologist, you see a pulmonologist, you see a urologist, you see a lot of ologists.
Sure.
And they basically, we don't really communicate with each other, and often it gets very confusing about what's going on. Add on top of that some mental health issues, some substance abuse issues, and often there's great confusion about what the patient is taking, is not taking, what's being done, what's not being done. So the idea of the medical home is to try to integrate all that information into one central source. That's how it started, and one place would be the sort of the gateway for that information to flow in and out. It then took on the idea that, okay, that's good, and electronic medical records and things like that help with that sort of thing, but then, okay, how do we actually integrate care? And that has become kind of a push with our patient population, especially getting behavioral health directly involved with their care and vice versa.
I would just think that that works so much better in delivering care to the whole patient, because a lot of offices or practitioners, doctors, nurse practitioners, whatever, they look at this and say, well, I can only deal with this part of it. You got to go somewhere else. Or they think, this patient has too many problems. I can't really deal with all of them. But it seems like in your situation, if you have a behavioral health issue, you have Louise.
And that's exactly what happens. Dr. Klein often walks patients up to my office and says, can you meet with this person?
Whether she likes it or not.
I'm sure
we call it a warm handoff, and it works beautifully. You know, I appreciate when he does it, and the patient appreciates it. Really feels cared for, you know, that he takes the time to do that. And I think, as Wesley mentioned before, since addictive disease and mental health are two huge problems among the homeless or at-risk population,
no question.
Behavioral health is, you know, we think of primary care or primary health problems and behavioral health problems as sort of being inextricably intertwined. That you often, he often will say to me, you know, a patient will come in, it's a medical visit, and all they talk about is their mental health problems or their depression. So that's where we can really work together. And I would say too that I think a common denominator for many of our patients, maybe most of our patients, is some sort of history of trauma. And trauma is, there's a broad spectrum. It can be some kind of history of, whether it's in childhood or adulthood, neglect or abuse, living with substance abuse or domestic violence or something like that. And you know, even though the addictive substance and addiction itself is a primary illness, there are many symptoms that don't get addressed in the medical arena. So I'm talking about psychological symptoms and emotional symptoms, Just to give you an example, a psychological symptom that we see with addictive disease is people tend to be very negative, and the cup is half empty, and it's sort of have a very negative outlook on life, and tend to be blame other people for their problems and so forth. And so that's the part the therapists work on. That's not something for a medical provider to work on. And
you would touch on it, but you can't spend a lot of time on it.
I think a really good example of what works well at Duffy as far as integrated model of care and the patient-centered medical home piece is our substance abuse services. And maybe Wesley and Louise can talk a little bit about the Suboxone program that we run and the Vivitrol program that we run and how that integrates.
What was the first one? The
Suboxone?
Suboxone?
Yeah, Suboxone. Yeah.
Okay,
you haven't heard of that.
No,
Well, let us educate you.
I need to be
We'll be
educated.
happy to put that down. We'll tell you all about it.
You know, as everyone knows now, opiates are a huge problem, not here on the Cape, but all over the world, and it just, all over the U.S. for sure. And it seems like, you know, for a long time, there basically was not many options, basically methadone or abstinence, and that really was it. There was a medication that was used as a pain medication for a lot of years called buprenorphine. And it became apparent that this had some properties that might make it useful as a treatment for addiction. What it does is it binds to the same receptors that opiates like heroin bind to, but not quite the same way, where people don't get high, but yet they don't crave and they don't go through withdrawal.
Sure.
So it also, at the same time, kind of blocks that same receptor, so if people do use heroin or other opiates, they don't get high from it. And so the idea is that a person would come in that is using an illegal substance, either they're buying Percocets or oxycodone or whatever on the street, they could start a program like this. They come in, we give them the first pill, they then will kind of get the dose right. It's usually pretty easy to do. They then come back, at least at first, weekly. They get a 7-day script, and we basically monitor them. We have a nurse who is specially trained for this and sees them weekly. We check their urines, we get them in with behavioral health, and so it's an integrated program. It is the medical home idea that they're seeing the RN for their weekly visits. They see behavioral health every 2 weeks to a month. They see me every 2 to 3 months, and everybody is kind of on the same team. Periodically, we staff them, meaning we meet about them. If there's problems, if their urine drug screens are coming up positive for other substances, do we need to get them off the program? Do we need to taper them? There's all kinds of things that come up. Or they're not engaging in behavioral health. They really aren't doing what they need to do. So this medication allows them to work on their recovery, work on the skills, work on what is really maybe driving their addiction, and not going through withdrawals and those same things.
Terrific. That's a terrific program.
Yeah, and the message is that it's not just about the
pills,
medication, that it's more than that. And in terms of behavioral health, we not only have therapists on the staff, we also have a psychiatric nurse practitioner, because again, we talk about trimorbidity, that our patients have trimorbid conditions, meaning primary health problems, mental health problems, and addiction problems. So the psychiatric nurse practitioner can evaluate them and prescribe medications for things like bipolar disorder or PTSD or major depressive disorder and things like that. We also have group treatment. So patients often have they have the full menu of our services. So
it seems that your clientele, and your clientele is not probably unique to the general population, except the fact that it's progressed enough that they're homeless or
at risk of homelessness.
Or at risk of homelessness. But I think this kind of integrated approach just makes perfect sense in healthcare. There's probably patients out there who have loads of money, never going to be homeless. They have tons of money, and they're still addicted and need the mental health care services.
They don't have the advantage
But they don't have the advantage of, they go to see one practitioner for one thing and one practitioner for another, and then they don't have any way.
And that is a big problem in addiction medicine, when most private doctors that do addiction medicine, they do stress the behavioral health part, but they don't have it in-house.
Right. Sure. And they can't really monitor
And they
it.
can't really monitor it. And it's always kind of a sticking point, because they can say they're seeing their therapist, but unless you physically call or get notes.
And the providers don't know each other.
They don't know each other.
Right.
And you have, so they can't, you can't go in a meeting and say, what
So
about Mary Smith? You
Yeah,
know,
right,
yeah. Yeah.
how's she coming?
Yeah.
And I think too, another one of the symptoms with addictive disease, I think if you go back to the idea that many of our patients have had some experience with trauma, you know, people learn different coping skills
Sure.
when they're growing up. So if they're dealing with a chaotic situation or a very unsafe situation, they may learn that it's safer to lie than tell the truth. You know, so certainly they come to us.
You had a patient lie to you?
Just once in a while.
Okay, all right.
Only one, maybe
Never
once last year. Yeah. And if they come to us with those behaviors, you know, sort of the figuring out how to get over on us,
how to work the
how to
angles.
work
Right.
us, and there's not as much splitting because we're communicating with each other. You know, we go to each other's offices with our patients, and part of what we're trying to do is help them learn. Sure, those coping skills, manipulation, that probably worked to keep you safe, maybe keep you alive, help you survive when you were growing up or whatever. But in adulthood, you know, going forward, you want to learn healthier coping skills, and that's what we're about.
And it may never get them out of their potential to be homeless or their homelessness situation.
You're right.
By continuing that behavior. So I just think that's
It's an
is this a
advantage.
new approach, or am I just that far out of
Well,
it? It
patient-centered
just-
medical home is definitely a new.
Well, it depends. In some
You were saying
iteration.
earlier that it's been around for a
Since
long
the sev-
time, but
they
it's
talked about it in the
right.
70s.
But it's now something that a lot of practices are striving
Yeah, it's sort
to
of
achieve.
getting a little more traction now,
Right.
and it's becoming where you can become certified. They actually have criteria for it, and you have to do.
But you know what? We're leaving out a really important element, the third leg of the stool, because
case
we don't have a
management.
case
Case management,
manager
right.
here to speak up for case management.
absolutely. That
And
makes
that's a
perfect sense.
critical member of the team, because they are the ones who will drive patients to appointments or pick them up
Sure.
and
Call
take them to court, to Social Security, you know, really help them find resources. They are invaluable.
Right.
Terry, another one of the things that these people do as part of the patient-centered medical home piece is something called a huddle, and it's a wonderful concept, and I think you guys should talk about it because I think it's another example of what works with the patient-centered medical home. So go for it.
7:30 every morning before we see patients, everybody gets together, and we sort of go through the list of patients we saw yesterday to follow up on problems, and then talk about the new patients and if there's any procedural things or things like that. We kind of go over it. So it's kind of a little quick 10-minute, you know, get together to kind of, okay, let's, it's sort of like planning your day. You
Absolutely.
know, sort of like, what do we need to do? Who needs to do this? Let's follow up on this. Or if I saw a patient yesterday, I go, Louise, I saw blah, 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 and they're in trouble or whatever, you know, the same sort of thing.
As an example, Wes might bring somebody up to my office and say, this person is, with the patient there, using drugs, really having problems stopping, he wants to stop, can you talk to him? I'm really worried about his liver functions, he's headed for hepatitis C, cirrhosis, whatever. And then I talk with the patient says, I have no intentions of stopping. I'm not ready to stop right now. I'm going to continue using. And that might be something.
That helps me. I need to know that because I could go full bore at this.
Yeah.
But the truth is, it won't go anywhere.
Right.
The patient has to be, again, patient-centered.
Right.
If you're not willing to take that
Right.
first step.
And so what we use is motivational interviewing. That's our technique, because that goes right with patient-centered medical homes. So our job is to elicit from the patient what is important to you. What do you want? You know, what are your values? What are your core beliefs? What do you want your life to look like? So patients will often tell us, well, I want I want to be trustworthy, I want to be honest, I want people to be honest with me, I want to be responsible. And so we can sort of point out to them the discrepancy between what they say is important to them and what they're doing. So, well, you're saying you value honesty and responsibility, yet you're missing all your appointments, and you're telling me you're sober when you're not, and so, you know, that's how we try to work with them to help them. So it's their idea about not, you know, I really think you need to do this.
Right.
It's got to come from them.
And I can see how important it is for you to do, if you're doing one thing, that the medical care is coordinated and the case manager is tuned into the whole piece too.
And it is.
I think that's such a great way to work, and a real benefit. It seems like it should just be done. There should be other clinics that do this same kind of thing.
Maybe someday. You know, maybe someday it will be like that.
It's very
I'm an optimist.
Because I swear there's patients, there's people out there that are doing it, could use all three of those things.
For sure.
To start with, you know. But what a great setup, and a fascinating piece. There's always so many things. In 2 minutes, Elise, what have we missed? What have we not talked about? There's a ton of stuff, and we want to get it back, and I just want to let people know at home, we're going to start producing these on a more regular basis because the community needs to know about Duffy, what important work you're doing, why you're providing it, so when they see it, and we all do this, we work and we think everybody knows what we're doing, and so then someone in your own family goes, what do you do? Where are you working now? You work at the hospital, right? You know, and you go,
what's Duffy?
Yeah, right, what's Duffy? You know, they say that, but that is exactly what happens. What have we missed?
Well, I think it's really important to go back to the whole idea of people being at risk of homelessness, because that is an area that we feel is untapped, and the people who may not consider themselves eligible for Duffy services may be eligible for services, and they should come in and be seen by us.
That's a great point.
That's a really good point.
That is a great
point. And we also, you know, we talked kind of in broad strokes about the substance abuse treatment program, but the substance abuse treatment program is a really great model of care that we offer at Duffy as well. So if people are struggling with opioid addiction or a heroin addiction, that is something we can work with people on. Great. And if you know somebody, or if somebody who's watching knows somebody who could benefit from our services, they should definitely come in and be seen by us.
It seems like you have the facilities set up now to say, if you come in, we can put you in the right, we'll put you on the right team.
Track, right.
You know, make sure you're going in the right direction.
Right.
And we have a staff that is unparalleled in dedication.
Excellent.
So,
that's great.
Yeah.
Louise, thank you very much for your help. Dr. Klein, thank you for being here. We appreciate it. And Elise, thank you for helping us put it all together.
Terry. Thank you.
And we're going to do it more. I've said this about 5 times. So thank you for watching. Duffy Health Center, a really important aspect to life on Cape Cod. Thank you. Thank you, folks.
Right.